Of course, it's not the actual screening that prevents cervical cancer. Vaccination does prevent cervical cancer, and that's wonderful, and we must embrace it and yet screen the remainder. But in a screening program, it's not actually the screening that prevents cervical cancer, whether it's HPV screening or cytology. Rather, it's the management of people who are screened positive. So when you embark on a screening program, you then have created some work for yourself. But that work is very rewarding because it's almost entirely preventive. And in fact, the complications of treatment are very small. And I'm not going to talk about treatment today. I'm going to talk right now. I'm going to talk about colposcopy. Nomenclature and terminology, it's a bit like diazepam, particularly if you put the subject on just after lunch, when everybody is sitting quietly and the blood supply, the major blood supply in your body is going to your stomach, not to your brain. So this is the death time to give a talk. Everybody's very comfortable and they're very sleepy. And nomenclature is not exciting. Nobody likes to talk about nomenclature. But I can guarantee you, if you get a nomenclature committee together, they will fight like cats and dogs to get their terminology. You will remember it, Mario. It's amazing. But progress in terms of how we've evolved in the prevention of cervical cancer and any disease, it evolves from a very clear understanding of existing research and then clarity of terminology amongst people who are talking about the subject. If one group in Saudi is talking about apples and one group in Dublin is talking about oranges, we're never going to make progress. And that has happened in nomenclature in cervical disease. So, cone biopsy, for example. In the US, a conization or cone biopsy means excision of any kind of TZ in a lot of publications. Whereas in the UK, conization or cone biopsy means a very precise thing. It means excising a significant proportion of the endocervical canal. And they're very different in the different publications. Also, in publications, people talk about the height of the excised specimen. For some people, they see the height. Other people call that the depth. Atypia is also another word that's widely abused. And comparison between atypia in Germany gives you completely different results. As I said before, practice varies throughout the world, and I won't repeat what I said earlier. Okay, Hamburg is where it all started. When I started doing colposcopy in the 70s, image recognition was thought to be really, really important. We spent a huge amount of time trying to discriminate between CIN 2 and 3, between CIN 3 and microinvasive disease. And we didn't treat anybody unless they had CIN 3, so we thought that was really important. More recently, I think that a colposcopist is now challenged not with the task of discriminating between CIN 3 and micro. It makes no difference, the treatment's the same. And not even perhaps between CIN 2 and CIN 3 in women who have finished their family or who are over 35. Rather, it's in the discrimination between a normal cervix and an abnormal cervix. And in a woman, more and more commonly, the smear report comes back with a borderline or a low-grade smear. And that's the population where the colposcopist's expertise is really challenged. Also, its role is not just that, it's also in facilitating precise treatment such that you treat completely the disease and don't treat excessively or remove or damage any normal tissue. Modern colposcopy requires objective and easily acquired skills through structured training as part of a quality assurance service. And if you're not in a quality assurance service, you really are going to have a disaster when you implement a screening program. The screening program in the UK and Ireland has two important components: high coverage and quality assurance. If you get those two right, your program will be a success. Also, more recently, and Mario Sideri's done a lot of work on this, risk assessment using biomarkers and patient characteristics will inform us in our decision about what to do with a patient. So it's not just that she's got a mildly abnormal smear or is HPV positive. It's how old she is. Has she finished her family? Is she going to default? How big is the transformation zone? Is it in the canal? Will treatment compromise future pregnancy or not? Will she default from follow-up? Those characteristics need to be included in the assessment of whether to treat or not. And we'll talk about treatment tomorrow. Colposcopy is not a defined entity and performs differently in different settings. Treatment is not a defined entity and produces different results and complications in different settings. And I'll talk about that tomorrow in the treatment lecture. But nomenclature varies in interpretation, and we can't easily compare practice unless we agree on a standardization of practice. I'm very pleased to say that the Japanese have rejoined the IFCPC, and one of the reasons that they did, and I understand the most important reason they did, was because of our new nomenclature. And they see nomenclature as very important. They're very precise at diagnostic levels. And I think the new nomenclature is likely to bring people in together. The Germans have just translated the nomenclature and published it in their journal in Germany. I think the French are doing the same, and the Spanish are doing the same. And we hope that we'll get global agreement about what we mean when we describe colposcopic examinations. Okay, I'm going to skip this section because it's on treatment. No, I won't skip this section, sorry. Just to emphasize how important it is that we do colposcopy properly. There's a debate going on about the value of colposcopy around the world. And some people in the US, and not at all of them, but a small group have argued that colposcopy is not valuable, and what you should do instead is take 4 random biopsies. Do a colposcopy by all means, but the important thing is the 4 random biopsies. And in their study, they found that they missed 11%, nearly 12% of CIN2, and this is a big study, the ALT study. In a comparative study in the UK, and there are now 3 or 4 similar studies, 95% of CIN2+ was found at the original colposcopy, compared to only 72% of CIN2+ found in the original colposcopy in the American study. So in the American assessment of colposcopic validity, of colposcopic performance and test characteristics, it didn't perform well, whereas in the UK it appears to perform well. And I would argue there's a very good reason for that. In the UK, colposcopy, the risk of a missing high-grade disease appears to be much lower. And I think the reason for that is because we have a very comprehensive training program. It's preceptor-based. There are a strict number of cases you have to perform under supervision, and subsequently a strict number of cases you have to perform unsupervised. There's an ongoing assessment of your performance during training, and there's an exit exam, an OSCE exam, of which 30% fail. Following that, colposcopy is performed in devoted clinics, not by individuals who do lots of obstetrics and lots of gynae-oncology and lots of everything else, but people who have a devotion towards colposcopy, who spend a significant amount of their time doing colposcopy. Women don't have colposcopy unless they've got an abnormality in their smear or they have a sign or a suspicious symptom. The rate of CIN is therefore relatively high. People are not rewarded according to procedures performed, and there's a comprehensive audit of practice. You have to get reaccredited every 3 years. I'm going to skip this because that's treatment tomorrow. But I would argue that if you're going to do colposcopy, do a lot of it. If you're going to train in colposcopy, train properly. And if you have a low rate of abnormal smear or abnormal screening tests in Saudi, decide who's going to do the colposcopy and get those few to do it properly and to do a lot. And other doctors can do ultrasound. Other doctors can do reproductive medicine. Other doctors can, in other words, I'm promoting subspecialization. Colposcopy has led the way in many countries in training and accreditation and quality assurance. The worst thing for Saudi would be if everybody did colposcopy in every office and did it badly and saw a small number of patients and didn't maintain the expertise that they gained through a comprehensive training program. But I leave all that aside. I'm now going to talk about nomenclature. The 2011 IFCPC Colposcopic terminology, which was published recently, has a few core features to it. There are basic definitions. I don't know how easy it is to read this, but the publication we will give you at the end of the course. Whether the square metal injunction is visible or not is important. Whether the examination is adequate or not is important. If it's not, why isn't it? And fundamental to this whole nomenclature is that if you're going to do a colposcopic examination, you need to record your findings. You need to record everything you see in a systematic way. You can't just draw a circle and say, Sin 3 here. You've got to describe exactly where the TZ is, what type it is, how big it is, what you found in there, not the diagnosis, what you found in there, and record it in a systematic way, and I'll come to that later. Normal colposcopic findings in the new nomenclature are original squamous epithelium, columnar epithelium, including ectopy, and whether the transformation zone is type 1, type 2, or type 3, and I'll come to what I mean by that later. Decidiosis in pregnancy and atrophic epithelium, Nabothian cysts and gland openings are all also normal features at a colposcopic exam. When you find an abnormal colposcopic examination, first of all, the general principles should mean that you will define whether the lesions are inside or outside the TZ, how many quadrants or how big the lesion is as a percentage of the cervix, and what happens when you apply Lugol's iodine. There are minor grade and major grade changes, and I'll describe those, and there are changes that are suspicious for invasion, and then finally there are miscellaneous changes. The nomenclature committee was large. Not everybody agreed about everything. One member resigned and rejoined, but we have ended up with a consensus about the publication, and it was supported by everybody. It's published in the American Journal, and I think it's also in the lower genital tract, but it's in this publication, and we can give you a copy of it towards the end. The committee has tried to establish an evidence base for the recommendations. There was a lot of discussion about keratosis versus leukoplakia, about whether lesions are inside or outside the TZ was important. The size of the lesion was a bone of contention. New features, new signs like the inner border and ridge signs, and treatment types were also added to the old nomenclature. Colposcopy is easy when you find clear vascular abnormality and acetic acid uptake in a large lesion that you can clearly see and not miss. Sometimes the features are so striking that you simply couldn't miss them, but sometimes they're more subtle. This picture shows some very high-grade changes, very widely spaced coarse mosaicism, dense aceto-white, coarse punctation, and where's Hisham, have we got the laser pointer? I don't know if that's possible to get the laser pointer. Could we get the laser pointer? Is it here? Excuse me, so it is. And then there's this vessel here, a so-called Pollarded Vessel. And that is a feature that's supposed to be associated with an increased risk of microinvasive disease in the presence of high-grade change. A Pollarded Vessel, a bit like the avenues of the south of France and the north of Italy, in villages and towns, where the branch is suddenly cut short. In other words, not like a branching tree, but where the tree branch has been cut short. So in this vessel, you don't see any branching. It arises and then stops. There's another example of it in a field of other vascular change. Here's a nice, relatively small transformation zone with clear margins on the outer limit of the transformation zone. Here's the same lesion with Lugol's iodine applied. Now, I'm afraid I've got the wrong colour of ink in this typescript, and I hope you can read it. The colposcopic features suggestive of high-grade disease really haven't changed from previous nomenclature. A generally smooth surface with a sharp outer border, and the border does seem to be important. Dense aceto-white change that appears early, appears rapidly after application, and is slow to resolve. It may appear oyster white. Iodine negativity, a yellow appearance in a previously densely white epithelium. Coarse punctation and wide irregular mosaic vessels of different sizes. And dense aceto-white change with columnar epithelium may indicate glandular disease, but glandular disease is very hard. Sharp border. Here's a sharp border. A sharp versus an irregular border. If your 4-year-old child can draw it, it's a sharp border. And the same lesion after, a clear lesion, columnar epithelium. What's that say? Oh, the new squamous columnar junction and crypt openings here. The original squamous epithelium out here. But the sharpness of that is evident. And that's the relatively non-mahogany brown uptake of Lugol's iodine. Some coarse punctation, some coarse mosaicism. And then the other changes that we described in miscellaneous: a polyp, atrophic epithelium, decidiosis. The size of the cervical lesion. There are a number of recent publications, and there aren't many, but they are convincing, that show a direct correlation between severity of disease and size of the lesion. And because of these, the committee felt that the size of the lesion should be included and documented. Should be included in the assessment of severity and should be documented in every case. This is a large transformation zone, and there's so much going on here. It's a joy to show it, so to speak, in that it's a large lesion, extending a large lesion in a transformation zone that's got variable degrees of aceto-white uptake. You see an inner border sign. So that this is different aceto uptake to this, which is different again to that. Now, this is not a good slide, and I apologize for that. The ridge sign is said to reflect a high-grade disease. And here there's supposed to be a ridge of elevated epithelium, and I'm afraid the blood obscures the picture a little bit, but that's the only one I've got. If you're trying to document your findings, and you look at the nomenclature table in the IFC publication, it's actually quite hard to do it for every case. There are a number of scoring systems that make it easy. The Reed score has been widely used. A modified Reed score has been widely used. And the one that I would recommend to you, that is very simple and I think robust, is a new one by Bjorn Strander called the Swede score. He's from Sweden. And it includes the aceto-whiteness, the margin status, the vascular abnormality status, and iodine uptake, as well as lesion size. It's a very simple table to document, and it will improve the diagnostic acumen. It will improve your colposcopic acumen, your recognition, and it will allow you, I think, to audit where you went wrong when you get the diagnosis wrong. So that there are only 3 scores, 0, 1, or 2. Acetic acid uptake, if it's shady, milky, not transparent, not opaque, you get 1. If it's distinct, opaque, and opaque white, then you get 2. And if there's none or it's transparent, you get 0. The margin status may be diffuse, sharp, but geographical, or sharp and even difference. Sharp and even, with differences in surface level, including cuffing around the gland opening. Vessels, you get no score for fine or regular vessels. You get 1 score for absence of vessels, and you get 2 for coarse or atypical vessels. The lesion size, 0 if it's less than 5 millimeters, 1 if it's 5 to 15 or occupies 2/4 of the TZ. 1 if it occupies 5 to 15 millimeters or 2 quadrants, and 2 points if it's more than 15 millimeters or 3 to 4 quadrants, or endocervically undefined. And iodine staining, you get none if there's nice brown mahogany staining throughout, 1 if it's faint or patchily yellow, and 2 if it's distinctly yellow. I want to talk to you about the transformation zone type, which I think is hugely important. And I personally advocate to our trainees that that's the first thing they should document. First of all, they should be able to comfortably pass a speculum, comfortably position the speculum such that the cervix is visualized in a perpendicular way. And secondly, they need to decide and define what the TZ type is. A type 1 transformation zone is completely ectocervical and therefore fully visible. It may be small or large. A type 2 has got an endocervical component, but it's still fully visible. You can see it all, even if it's in the canal a little bit. And a type 3, you can't see it all. So that's a type 1 TZ. Very clear, very obvious. It's on the ectocervix. You can see it all. And this is an example of that. Mario, I've stolen a couple of pictures from your library, which will be on the IFCPC website very soon. And Mario, myself, Jim, and Usha from India examined a number of images and tried to see if we could agree. And this, most of us thought was a type 1 transformation zone, both of these two. A type 2 has an endocervical component, but is fully visible. It may have an ectocervical component, and that may be small or large. So that here you can see the transformation zone in this slightly opened cervix with the speculum in situ. You can see that the transformation zone extends into the canal, but you can actually still see it. So that's a type 2 fully visible TZ. This is another type 2 fully visible TZ, though one of us thought it was a type 3 because it wasn't very clear there. But in reality, you almost certainly could see that with an endocervical forceps. A type 3 transformation zone, on the other hand, you can't see the whole TZ because it's in the endocervical canal. And this is an example of that. You simply can't see above this limit of visibility to where the extent of the TZ is. The same with this. It extends out of view on the anterior lip. You can't see the upper limit of that transformation zone. And the same with this, where there is clearly abnormal epithelium. I don't know if it's possible to turn the lights down in the front. Is that possible? It just, for our videos later on and for some of these, I think you'll get better vision if the lights go down at the front. I don't know which idiot of the three of us said this was a type 2 transformation zone, but it's clearly not fully visible and should be a type 3. And again, this is a type 3 where we all agreed you could not see the upper limit of this transformation zone. And whilst it's a small transformation zone, it's got very definite densacetowhite epithelium, and it's not fully visible. If it's not fully visible when you do your original colposcopic examination, of course you can try and make it fully visible by using an endocervical forceps. This is a Kogan's forceps. The one I showed you this morning was a Desjardins, and there's also one called Curry-Harry, which I think is probably the best. The Germans wanted to change type 2 transformation zone into type 2A and type 2B. Type 2A being you can see it without the aid of an endocervical forceps, and type 2B meaning you had to... But the committee couldn't agree on that. They started throwing apples at each other at that stage, and bits of stale bread. So type 2 is simply type 2. Whatever way you do it, if you can see it completely in the canal, it's a type 2. If you can't see it, it's a type 3. This is a slide from Patrick Walker where he puts the endocervical forceps into the vagina, coming in from the side of the speculum, whereby he thinks it keeps the endocervical forceps out of view and out of the way. I don't tend to do that. I use a Curry-Harry. But that's as you can see, by so doing, you can then look in the canal and see the upper limit, where perhaps before you couldn't see it. In order that we are able to evaluate the true morbidity, success and failure rate, and complications of treatment, the Nomenclature Committee thought it was very important that we include transformation zone excision types. So not just TZ types. This is a new thing. It's excision types. And it's very simple. A type 1 excision is an excision of a type 1 TZ. A type 2 excision is an excision of a type 2 TZ. A type 3 excision you may use in different circumstances. You may use it to excise a type 3 TZ. You may also use it if you suspect glandular disease, or if you suspect microinvasive disease, or perhaps if the patient's had previous treatment. So type 3 excision means you're excising a significant proportion of endocervical epithelium in the belief that there is endocervical disease. And a type 3 transformation zone is a different kettle of fish in terms of treatment to a type 1 or a type 2. And I'll talk about that in the treatment lecture tomorrow. A type 1 excision can be used for any grade of disease. Probably should always be excision for SIN 3. Whether you use LET, sleep, or laser excision, you can even use ablation for type 1 TZs, though I personally don't. And a type 2 can be used for any grade of squamous CIN, perhaps glandular disease in women under 36, and we'll talk about that tomorrow, or whether it's previous treatment. And whether that's a LETS, a LEAP, a SWETS, or a laser excision, or cold knife biopsy, depends on the individual. I think you've had enough before you fall asleep completely, particularly as the lights have gone down, and I can see a few of you stretching out already. I think I'll stop my talk, and again, invite you to come to the 15th World Congress of the IFCPC in London later this year. I thank you for your attention.